I decided to talk about protective equipment today because I think there's a great deal of concern. I think the word PPE or the initials PPE have probably been pronounced more on television in the last month than they have in the last, since the term came out. We have reason to be concerned as healthcare providers because there is a significant degree of toxicity, of infection and a fair number of deaths among healthcare providers. And so I'd like to address that today. This is a strange new world that we're in. I'm going to talk about PPE practices with a critical eye because I would argue that whatever we're doing is not enough in terms of protecting healthcare providers. I'll show you some statistics from around the world and what few statistics we have from the United States about healthcare providers who are infected or have died. I know that hospitals and administrators, universities, and public health officials are doing their very best with what is available to them in terms of supplies and their attempts to be compliant with CDC recommendations and with best practices. But I think something is missing in what we're doing, and so I want to bring up some suggestions. I have questions myself about which of these things might work, and I think we all need to work together to bring this degree of disease down and to get it under control. So my opinions are just that. I don't represent my institutions in terms of my opinions. We are sponsored in some form through the APSDR and US EPA for our Pediatric Environmental Health Specialty Unit. I also don't represent their agency policies either. Our objectives today are to for you to appreciate the impact of COVID-19 infection among healthcare providers, both here in the United States and elsewhere. We're going to talk about the role of personal protective equipment in the context of other preventive measures, and we'll look at some interventions, some changes perhaps in PPE use that may reduce the incidence of COVID-19 illness among healthcare providers in particular. So we will look at the incidents around the world and back here in the United States. We'll look at regulations that deal with PPE, certification, provision, testing, et cetera. We'll take a very brief look at a couple of studies from previous viral epidemics, and then we'll talk about actions to diminish the likelihood of infection in healthcare providers. I apologize, I'm a little hoarse today, and it may get worse, but I'll do my best to keep my voice up. So I'll start with a pretest here. Healthcare providers make up less than 1% of all COVID-19 cases. Is that true or false? Well, if it were true, I probably wouldn't be talking about this. It is false. Healthcare providers make up more than 10% of COVID-19 infections in multiple countries. Due to a paucity of testing here in the States, it's not really possible to estimate accurately the number of infected healthcare workers here. We do have a little data, and I'll talk about that as we go on. Second question, true or false, there are no significant risks associated with extended use and reuse of N95 respirators. That is also false. NIOSH, the National Institutes for Occupational Safety and Health, warn that some of these devices are only supposed to be used one time. They've not been tested for multiple uses in many cases. The most significant risk is of contact from touching the surface of your respirator. In one study by Redmond, she found that nurses on average touch their respirator, their nose, or their face 25 times in a shift. True or false, the U.S. OSHA, Occupational Safety and Health Administration, and the CDC consider surgical face masks and N95 filtering face pieces to be equivalent PPE for healthcare providers. And the answer to that is also false. Which just says the N95 may be replaced with another respirator equal or higher protection, such as an N99 or N100. Reusable elastomeric respirators, that would be a gas mask type with filters, or a PAPR. The CDC considers medical face masks as acceptable alternatives when more effective respirators are not available. So is it just another day at the office, or the first day of the end of your life? That may be a little bit hyperbolic, but I will explain to you why I have significant concerns about what we're doing in terms of protecting healthcare providers. So there's a lot of fear out there, not only on the part of the public, but the healthcare providers as well. If we look at China, where this presumably started, back in February, early February, they announced from their hospitals that they had 500 sick healthcare providers in China. Less than a week later, they announced that that was actually 1,716 healthcare providers with 6 deaths. As of March 21st, that number had grown to 3,300 healthcare workers infected and 22 dead. In Italy, this was the first physician to die. This is Dr. Roberto Stella. And a few days before his death, he told a colleague, "We've run out of masks, but we don't stop. We're careful, and we go on." Unfortunately, he's not the only one in Italy who's died. This medical society, the National Federation of Surgeons in Venice, now lists more than 80 physicians who passed away since March the 11th. A total of 4,826 healthcare workers as of March 22nd had been infected by the coronavirus, or about 10% of their cases of COVID-19 have been among healthcare workers. Dr. Anelli, who's with the same society, said that after 2 months of this disease, there's still plenty of physicians who have to work with no gloves, and they're devoid of the most basic personal protective equipment. The physicians there are quite angry. In France, 5 physicians have died. All 5 were older, between 60 and 70 years old. 1 emergency physician, 3 generalists, and a gynecologist made up the list. They didn't mention nurses in this article at all. However, if you look at the Assistance Publique, which is the public assistance hospitals in Paris, which are the majority of hospitals in the city and the region around it, there have been 1,200 professionals of APHP who become contaminated with the virus, with the proportion represented by physicians up to about 40%. In Spain, they're even worse. More than 13% of Spain's 40,000 cases are among healthcare workers. There are 5,400 health workers who contracted the virus. They haven't published, to my knowledge, anything about the number of deaths among physicians and nurses. We haven't been spared here in the United States. Just recently, March 25th, the governor of Ohio, the Department of Health in Ohio announced that healthcare providers constituted 16% of their COVID-19 cases. And even more recently, the Minnesota governor said that 28% of the COVID-19 cases were in healthcare providers. He argued that none of them were contracted at the hospital, that all of them were contracted during travel. And I'm not sure what his evidence for that was. Peter Hotez, who's the dean of the National School of Tropical Medicine at Baylor, pointed out that it's not just that healthcare workers are getting infected, but they're getting sicker than one might expect on the basis of their age. And he indicated that he thinks it's from higher exposure doses to the virus. There have been hundreds of healthcare providers in New York who have become infected. 2 city hospital nurses have died. One New Jersey physician has died. And there were more than 200 healthcare providers in a single hospital that have become infected. The City Health and Hospitals Corporation has essentially stopped talking about how many sick medical workers they have. It's very difficult in the United States to get information about how many healthcare workers are sick and how many have died. It seems almost impossible to me that the CDC has not begun an epidemiologic investigation of this problem to see what factors could be contributing to the higher incidence of illness in physicians and nurses, even when they're using protective equipment. And MIT actually started a voluntary registry a few days ago to register the dead, and they've got over 100 on their website now. If it weren't bad enough for people to be getting sick and dying at work, hospitals in some places are actually preventing physicians and nurses from trying to protect themselves. Natalie Buckaloo is a local attendance physician. She went to a hospital in Boise with her N95 mask. They told her to take it off. That's why they told her it was against hospital policy. And when she asked to see the policy, they said, well, it's because if you wear your mask, others will want one, and we don't have enough. And finally, they told her CDC guidelines don't require the mask all the time. She refused to take it off and was fired, and she filed a complaint with OSHA. A Washington emergency physician has also been fired after publicly criticizing his hospital for not protecting its staff. He published some things on social media and became a local cause célèbre, and he is now out of the job. You have to ask yourself whether people who question their employees and government officials over the adequacy of PPE should be tolerated. Apparently, there's some hospitals that think the answer is no. But here are the facts. Healthcare providers are becoming infected with SARS-CoV-2 at an alarming rate. We don't know, for the most part, whether the sources of infection are inside or outside the healthcare facility. And the only way we'll really know is if we do widespread testing and contact tracing and perform an epidemiologic study. So we know that healthcare providers have families who may be infected and go to the grocery store like everyone else. So it's possible that some of these cases, and maybe many of these cases, are being contracted outside the hospital, but we need to know. The questions that we need to ask about PPE are, is it being consistently worn? If it's not, is it due to unavailability because it's not being supplied? Is there lack of training about how to put it on and take it off correctly? Does the hospital have a policy that precludes them from using the PPE that's needed, or is this a provider choice? Have they received adequate training? Is there a problem with work practices, such as donning or doffing equipment, inadequate fit testing, cleaning for use, which can result in damage to the respirators, or inadequate hand washing? And finally, our assumptions that we have now regarding the required level of PPE, and that is a simple face mask versus an N95 or a PAPR for each type of patient, are those assumptions faulty? So let's look at transmission and disinfection for a moment. SARS-CoV-2 is about 150 nanometers in size. And up until a week ago, it was generally considered to be transmitted by respiratory droplets that are greater than 5 microns in diameter and by the contact route, rather than by airborne dispersion through droplet nuclei, which are smaller than 5 microns. This has been called into question recently by a letter from the National Academy of Sciences, and I'll talk about that shortly. Transmission thus occurs direct person-to-person contact and indirect contact with fomites, such as your stethoscope. And again, this new NAS report, which I'll talk about shortly, cast doubt on the possibility of airborne dispersion. Here's some other fomites you might consider. We go in and out of hospital rooms and use the keyboard. We use the door handles. We use the dictaphone. We use the telephone. Did the last guy who used this wash his hands? It's a good question to ask. And how often are these being decontaminated? In terms of the stability on the surfaces of materials, SARS-CoV-2 has been subject to only a few studies, but this is one that's been done recently in comparison with SARS-CoV-1, which caused the SARS illness back in 2003. You can see at the bottom that the times that these viruses remain active are very similar depending on the material that they're residing on. For cardboard, it's generally less than 24 hours. For stainless steel, again, around 24 hours. And for plastic, it can be up to 72 hours. And that's shown up above as well. So the COVID virus does stick around on surfaces. There's not been much done about COVID virus, COVID-2, as far as I have been able to find in terms of persistence on PPE. But they believe that these studies dealing with other coronaviruses, SARS-CoV-1 and the human coronavirus, would yield similar results with the SARS-CoV-2. So on paper, it can last anywhere from 24 hours to 4 or 5 days, depending on the strain. On surgical gloves, the human coronavirus can last up to 8 hours. And in a disposable gown, it can be from an hour to 2 days, depending on the size of the inoculum. We also know that airborne transmission may occur when we do procedures that generate aerosols, and this should be of grave concern when we're doing bag mask ventilation, endotracheal intubation, suctioning, bronchoscopy, and other treatments. In terms of inactivation of coronaviruses by biocides, ethanol at 80% will destroy the coronavirus after about 30 seconds. And log reduction is greater than 4 for 80% ethanol. And you can see the figures there for sodium hypochlorite. We probably all heard about people slathering hand sanitizer on their masks to try to make them last longer. And that seemed like, looking at this, that would be a logical thing to do. Unfortunately, what happens with ethanol or isopropanol is these masks, and particularly the N95, are what are called electret filters. They depend on static electricity to stop part of the virus particles or whatever particles are going through. And if you dip them or soak them in alcohol, you destroy the charges in the mask, and you'll actually increase the penetration of particles, and larger particles will pass. In one study, if you soak the mask in ethanol for about a minute, I believe it was a minute, could have been longer, there was about a 20% increase in penetrance of particles, and the particle size that penetrated quickly went from 118 nanometers up to about 400 nanometers, so much larger particles made it through the mask. This is what I call the bombshell, because this came out last week. The White House asked the National Academy of Sciences for a rapid expert opinion about whether or not SARS-CoV-2 could be spread by bioaerosols. And the conclusion was that yes, research supports the possibility that simply by exhalation, you can generate bioaerosols that can induce disease. The degree to which that occurs apparently differs quite a bit from one person to another, and would have a bearing on the efficiency of transmission. But the bottom line was they concluded that you could be infected by an asymptomatic individual. Furthermore, the University of Nebraska has been doing some studies and found that even use of a nasal cannula can result in dangerous dispersion of viral particles. The same letter from the National Academy of Sciences quoted a study that was done in Wuhan, where samples were obtained in 2 hospitals in public areas. In patient care areas, the highest concentration of virus was found in toilet facilities, which makes me question whether or not we're doing enough to protect our sanitation workers or housekeeping staff. In medical staff areas, the highest concentrations were in personal protective equipment removal rooms. And the authors concluded that doffing PPE, cleaning of floors, and movement of staff might be causing a virus-laden aerosol to be resuspended. But the bottom line was from the NAS that the current SARS-CoV-2 specific research, however limited, suggests that it's consistent with aerosolization of virus from normal breathing. This, in my mind, raises questions about the kind of respiratory protection that we need to have in dealing with not only patients highly suspected of having COVID-19 disease, but those who may be, the 25 to 50% who may be asymptomatic and able to pass the virus on to healthcare workers and others. We know that PPE can protect us to some extent. We're also protected by rules and regulations in terms of certification, education, provision, and testing of PPE. It's important to remember that PPE is the last bastion of infection control. We look at this hierarchy and we try to eliminate risks rather than deal with them with PPE if we can. This has to do more often with hazardous chemicals, where either elimination or substitution can make a big difference. But if we fail in that, we move to engineering controls, and this is where we do airborne isolation rooms with negative pressure, administrative controls, cohorting patients, putting them in a tent, designating a single healthcare provider who may be antibody positive, for example, to deal with those folks, utilizing work practices like frequent hand washing and frequent disinfecting of surfaces. It's only then that we get to PPE. And we want to make sure that we're utilizing an appropriate personal protective equipment and that people know how to use it. So before caring for anybody with confirmed or suspected COVID-19, it is required that you receive comprehensive training on when and what PPE is necessary, how to don it, how to doff it, its limitations and proper care, maintenance and disposal, or in some cases, reuse. And you have to demonstrate competency in performing those procedures. PPE training is an imperative. It involves selection of the right equipment, fit testing, donning and doffing, and disposal versus reuse. The PPE has to be done correctly before you enter the patient area in an isolation room or a unit if you're cohorting patients. You have to leave it in place for the entire time that you're in the room and you shouldn't be manipulating your gown or adjusting your face mask or respirator during patient care. When you get ready to leave the room, the PPE must be removed slowly and deliberately in a stepwise approved process, and it's best to work with a partner. In the Dallas Ebola cases, as you will recall, there were 2 nurses that were infected with Ebola, and they had followed what they thought were appropriate recommendations of CDC to avoid infection, but they had been making mistakes in the doffing procedure. So CDC changed those procedures and required that they have a partner who watched them doff their equipment so that they could catch any errors. This is what CDC says is preferred and acceptable for PPE. The preferred PPE is a face mask or goggles, an N95 or higher respirator, one pair of clean sterile gloves, and an isolation gown. They consider it acceptable, however, if you have a face mask, if an N95 is not available. I would propose that adding a second pair of gloves adds significant protection to the ensemble. And this has been shown by Casanova in 2012. It's also standard practice in treating not SARS patients, but Ebola patients. And in fact, one recent article coming out from the NHS in the UK recommended 3 pairs of gloves. But having a second pair allows you to take off your gown without using your bare hands. The way that CDC recommends it, doffing is to take off your gloves and then to reach up to your shoulders and pull your gown down before leaving the room, and then doing hand sanitization. But you're having to put your bare hands on a gown that may be contaminated, and and close to your face. So I would argue that a second pair of gloves would be a logical step. This again is the issue that we had in Dallas with a couple of nurses who became ill. If you want a film to teach you how to do doffing and donning and doffing, the University of Nebraska has some excellent films that show you how to take off and put on a respirator, how to take off and put on your entire personal protective equipment ensemble, and I highly recommend those. If you're going to wear a respirator, if the hospital decides you need to wear a respirator to protect you from airborne contaminants, it has to be used in the context of a written respiratory protection plan. This includes medical evaluation, training, and fit testing. What are the differences between a surgical mask and a respirator? The surgical mask does not meet the stringent filtration requirements for certification. NIOSH certifies respirators in our country. That's the National Institute for Occupational Safety and Health. These surgical masks are not designed to filter small particles, but they do protect against droplet contamination. They're loose-fitting, and they cannot be fit tested, and thus they cannot be certified by NIOSH. They can't be seal-checked, which is where you put the respirator against your face and check for positive and pressure and negative pressure to see if you're getting any leakage, and shouldn't be used unless they're cleared by the FDA. They are less expensive, and they're generally more comfortable for wear. Particular respirators, and generally we're talking about the N95 here, are certified by NIOSH. They filter out smaller particles. They have to be fit tested initially and annually, and they have to be seal checked with every use. They should not be used unless they're certified by NIOSH. It's marked on the respirator. They are more expensive, and right now they're very difficult to come by. They have higher filtration rates and a tighter fit, and so they tend to be less comfortable to wear over time. Is a medical mask an acceptable substitute? The Institute of Medicine looked at this in 2006 in the investigation of pandemic flu response. They concluded that an N95 properly fit tested was likely to be the best protection, that a mask that was high efficiency could provide droplet protection, whereas a surgical N95 would protect against both droplets and aerosols. And finally, that masks are likely to provide less protection against aerosols, but may offer better protection than cotton masks, homemade alternatives such as handkerchiefs and scarves, or not having any protection at all. There have been some more recent studies, including one that was published in JAMA in 2020, that suggests that N95s and medical masks are roughly equivalent for influenza prevention in healthcare providers. However, some of the methodological issues have been questioned in that study. Fit testing is required if you're going to wear an N95. I won't go through this list, but again, you can learn about fit testing pretty quickly by watching one of those videos from the University of Nebraska. There's been a move by apparel makers to put out masks. They've answered the call for help, essentially, from the U.S. healthcare system. And that's a good thing, that they volunteered in many cases to produce these masks. It's important to realize, however, that commercial cloth masks are not very protective for anything less than 2.5 microns. And when tested against an N95, their efficiency is somewhere between 39 and 65% in a study by Shakya in 2016. And that the masks that are now being produced by new companies probably have not been tested at all. They're not NIOSH certified, they're not FDA cleared, and they may provide some protection, but it may not be enough. So NIOSH talks about how to extend the use of the N95 under circumstances where you need to the N95 and there are simply not enough to go around. First, you minimize the number of individuals who need respiratory protection by using engineering controls. Use alternatives to N95s like gas masks, PAPRs, etc. You implement practices allowing extended use or limited reuse, and we're going to talk about what the difference is there. And then you prioritize the use of N95 respirators for those personnel at the highest risk of contracting the disease. Extended use is where you use the same N95 for multiple patients, but you do not remove the respirator between patients. Limited reuse is where you use the same N95 for multiple patients, but you remove the respirator each time that you leave the room. There's some consideration that extended use may be safer because of this concern that self or auto-contamination with the virus is more likely to occur during the doffing phase of your care. And the second thing is the concern that the virus may be liberated into the air as an aerosol when you take off the mask or the respirator, rather. With the limited reuse, this is one of the problems that exists. Every time you put a mask back on, you need to adjust the respirator to make sure you have a comfortable fit, that it's tight, and that you have a good seal check. When you do that, you have to put your hands over a respirator that's potentially contaminated. And the longer you use it, the more likely it is to be contaminated. And you've got your hands right around your eyes, your nose, and your mouth. So this seems to me to be potentially dangerous practice. For decontamination of N95s, the CDC says this is not approved for routine decontamination reuse, but in a crisis capacity, in other words, with a lower standard of medical care, you may have to do this. They recommended UV radiation, vaporous hydrogen peroxide, and moist heat as the best potential methods to decontaminate FFRs, or filtering facial, face-fitting respirators, or N95s. They go on to say, however, that no current data has studied the effectiveness of these decontamination methods against SARS-CoV-2. Therefore, even if you decontaminate the mask, the respirator, they should be handled carefully, and they should not be worn when performing an aerosol generating procedure. So if you're going to intubate a patient, you need a new N95 or some other equivalent respirator, not one that's been decontaminated. That's direct from the CDC. The FDA issued an emergency use authorization for Battelle on March 29th, and it allows Battelle only to use vapor phase hydrogen peroxide to treat up to 10,000 respirators a day. It's not applicable to cellulose-based materials, and you have to send your FFRs to Battelle for processing. In this letter, they said that there is no adequate, approved, and available alternative to the emergency use of the Battelle decontamination system. If I were a hospital administrator, I'd be a bit concerned that this raises the level of liability if I were to choose some other decontamination system. And the last thing that they put in this letter just flabbergasted me. And that is, due to shortages of N95 respirators, healthcare providers may need to treat patients without personal protective equipment. I assume that they put that in there as justification for the emergency use authorization, but I found it just unbelievable. 3M, who manufactures a large percentage of the respirators used in the United States, as well as filtering face masks, has studied ways to disinfect or sterilize them. And they say that any method must be effective against the target organism, must not damage the respirator's filtration, must not affect the respirator's fit, and should be safe for the person. In other words, no off-gassing of chemicals into their breathing zone. They have concluded as of March 27th that there is no disinfection method that's met all four of these criteria. And based on that, 3M doesn't recommend or support attempts to sanitize, disinfect, or sterilize 3M FFRs. Now, you could argue that they have a vested interest in not seeing them sterilized because they sell more of them that way. But they are the manufacturers. They are the experts in the manufacturing of these devices. And so it's worth at least taking that into consideration. I want to bring up one study that was done during the SARS era. In 2003, in Hong Kong at the Prince of Wales Hospital, there were 138 SARS patients, 69% of whom were hospital workers. Overall in Hong Kong, of the 360 hospital workers that contracted SARS, they comprised 20.5% of all patients. And once again, non-medical support staff had the highest attack rate, followed by nurses, followed by physicians and other technicians, which again raises a concern in my mind as to whether or not we are offering adequate protection to housekeeping personnel, unit clerks, etc. They studied 72 patients who had SARS, who were healthcare cases, and compared it with 144 controls. This was a questionnaire study. They asked them about use of PPE and how they use PPE in three situations: where they had direct contact with SARS patients, when they had contact with patients in general, that would be other patients not suspected of having SARS, and no patient contact. Then they asked whether they never, occasionally, most of the time, or all of the time use their PPE, and about frequency of hand washing. The results were interesting. Cases complain more often than controls of inadequate supply of personal protective equipment. The cases were non-significantly actually less likely to have had contact with SARS patients, and the cases were more likely to have encountered one or more of the 7 problems that you see there. And so it's inconsistent use of PPE, absence or lack of adequate training in infection control, failure to understand infection control, shortage of one or more pieces of protective equipment, and inadequate or inconsistent hand hygiene when there was, quote, no patient contact, unquote. So our work practices can certainly have an effect on our likelihood of becoming infected. It is very important that not only we wear PPE when we have it available, but that we wash hands frequently and go through infection control training and PPE training that's necessary. So will we have enough PPE for the pandemic? These statements from the White House are a little bit disconcerting, if you ask me. Implications that nurses or physicians were stealing respirators, the president told the states to get it yourself, and then Jared Kushner told a group that the federal stockpile was their stockpile, which is the last thing from the truth. One of the reasons that we have a shortage is that China produces about 50% of the world's N95 respirators. They've obviously had a need for a lot of them. And there also was a 25% tariff on all medical supplies from China until March 10th and 12th, when the tariffs on PPE were lifted. There, on the other hand, have been no restrictions on exports of medical supplies. And even at the time that COVID cases have been rising, we've been selling PPE and other supplies, respirators, et cetera, to other countries. This Inspector General's report, which was roundly criticized by the administration, it was a survey of hospital administrators, and their results from asking for help. One said that the supplies they got wouldn't last a day. One received 1,000 masks, of which half were for children and unusable for staff. And one administrator received 2,395 masks that had to be thrown in the trash because the elastic bands had dry rotted. So supply is certainly an issue. Some possible solutions. Rapid testing needs to be largely expanded, including antibody testing for healthcare providers, so that those who have been exposed to the disease and are better can take the front line and care for patients with COVID-19 disease. There's not much that we can do to increase the availability of PPE as healthcare providers or even as hospital administrators. It's going to be largely dependent on state government and the federal government, and the responses have been mixed. Every healthcare provider should receive at least 2 hours of training on how to use and don and doff PPE. I would argue that based on the information that we've gotten from the National Academy of Sciences, that we should at least consider whether or not an N95 should be worn for all patient encounters, given that asymptomatic patients may have aerosol transmissions that cause disease. And it may be reasonable to wear an N95 throughout the entire shift based on the evidence of dispersion of COVID-19 particles. Lots of fomites exist. The respiratory protection of non-clinical staff, such as unit clerks and housekeeping, needs to be re-examined. Again, you should give thought to wearing a second pair of gloves to avoid potential contamination when you doff your gown. Frequent hand washing should be used, and because of the problem of fomites, there should be some consideration of whether wearing exam gloves pretty much all day would be reasonable. And some physicians have promoted showering and clothing before going home, and I think that's probably a good way to protect your family. Reuse of PPE should only be in the setting of crisis care. Extended use of PPE may be safer than reuse. And again, you need to wear a new N95 when performing aerosol generating procedures. Finally, I would argue that the hospitals, and particularly the CDC, should initiate case control studies to do contact tracing, to question infected healthcare providers, look at their outcomes, and try to establish where the holes are and what we're doing to protect healthcare providers from COVID-19. Finally, a little good news. For those of you who may have gone online to buy toilet paper and found it available at $6 a roll, here's some Nirvana. The Department of Health and Human Services and the Justice Department confiscated 192,000 N95 respirators from price gougers. They've been giving them to hospitals in New York and Jersey. And the second one is that in Texas, we've received a large number of respirators in the last few days. We'll be getting more soon. And so that's certainly good news for those of us here. Some useful resources. Again, these University of Nebraska films. They're also good films by Hippo. 3M has a good film on donning and duffing and seal checks and fit tests of the N95. I leave you with this last slide to say that we're not going to be out of the woods for a while. Wuhan just went below 3 cases a day of new cases, and that took 69 days. So if you look at the curves here for Lombardy, for New York State, they're probably going to be having cases for quite some time. Hopefully, it won't last as long as it did in Wuhan. But we need to remind our patients that they need to stay at home and not be close to others for a while. If you like the slides, just take your camera and if you have a QR reader or modern phone, you should be able to pick up this QR code and get the slides. If for any reason you can't, you're welcome to contact me by email. And that's all I have. Thank you.
Dr. Borron, I believe we had a couple of questions for you here. One of them was sent to me, so I'll read that to you, but it said, are there any studies about sterilizing N95 with UV light?
Yes, there are, and it tends to be very effective in terms of killing the virus. The one concern about it is that it actually, over time, will destroy the filtration layers, and actually can be quite detrimental. I've got that study somewhere handy. It's a study from a group called ECRI, which looks at evidence-based, where there are no published studies, and some cases where there are published studies. But it's an ECRI study, and I can provide that reference if anybody's interested. But the answer is yes, UV works very well to kill the bugs, but it damages the respirator over time, so they essentially will fall apart if you do enough sterilizations. So they generally limit it to just a few times.
Another question that came up is, How good of protection is a face shield against aerosols? Because we've been seeing that recommended a lot for eye protection, but the aerosols might waft around the side of the shield. So should we get a sealed face mask or respirator?
Certainly the a full face mask or goggles will protect your eyes better than a face shield. But I think in most cases, unless you're doing a procedure where you have aerosol generation, the face shield probably should be adequate. But for aerosol generating procedures, I think goggles or a full face mask or one of the pappers like we saw this morning, the more modern lightweight pappers would be preferable. Stephanie Weiss asks about wearing an N95 for the whole shift. Yeah, it would not be comfortable to wear an N95 for an entire shift. I'm sure of that. They get a little hot, they get sweaty, but they are more protective, certainly, than just a face mask. And you know, if the current iteration of what we're using for people were sufficient, I think we wouldn't be seeing so many cases of healthcare providers becoming ill. And so I have to argue that if we have it available, a higher level of protection is reasonable.
Dr. Kazi is asking if there's any update on antibody testing.
The last I heard was that we weren't going to see it in widespread until September, October. It's been approved, is my understanding. I think Abbott has a test that's been approved, but the production is going to take several months. And so they said widespread availability would be October.
Another question for you, Dr. Borron. They say for staff that have been exposed, quarantined, and have returned to work, can they treat now without the face mask, or are they still required?
If they are proved antibody positive and known to have had the disease, they could presumably, it's not known with 100% certainty that even the antibodies provide a foolproof method of preventing your being infected again. It's presumed on the basis of viruses treated in the past that antibody production should offer you protection, but it's not an absolute. And so, personally, I would not work without a respirator just because I had been exposed and showed some antibodies. But without antibody testing, I would not. I wouldn't presume that they could go without a mask in any case.
Thank you. And Dr. Kazi is asking, can you please elaborate more on the reason for the lack of sufficient amount of PPE in the United States?
It's my understanding that the Strategic National Stockpile has been depleted significantly because of materials that had been expired, and whereas some things in the stockpile can be used in spite of their expiration dates, some of these materials, like the example of the 2,300 P95s or N95s that came that had elastic bands, if they're expired and they're not functional, then they're no good. So the depletion of the national stockpile was part of it. The exclusion of China or the tariffs on China and other but I think also that when people started hearing about this disease, there's been a tremendous run on respirators by the public. And it's hard to compete with the public as long as they were able to get them to buying up these respirators. I haven't heard of other issues, but if Dr. Kazi is aware of something, I'd be glad to hear from him.
And I do have another one for you, Dr. Borron. They're asking, what are your thoughts about the use of other reusable respirators, such as the commercial ones used for gases, vapors, or paint?
Well, you don't want to use a vapor respirator because they're not designed for excluding particles. If you're going to use a gas mask or an APR, a simple APR, those are equivalent in terms of OSHA, but you have to use particulate HEPA filters essentially to get something that's equivalent to the N95. You would not want to use an organic vapor cartridge or an acid gas cartridge or any of the many other cartridges that are used for chemicals. You really need a particulate filter. And yes, those would provide protection.
Thank you. And Dr. Kazi, go ahead. I believe you had another question.
Dr. Borron, yes, I was asking about fit testing. You know, I really was last fit tested before I entered residency in 2000. Mm-hmm. And I believe the fit testing capacity is limited at hospitals. Have you had any experience with simple fit testing or something that you can do at home?
You can go online, and there are films about how to do fit testing. The non-quantitative fit testing is usually done with chemicals that you can either taste or smell, or both, and you could potentially do those on your own. Hospitals should be doing it because it's the law. I think the compliance is fairly low. I don't recall being fit tested for an N95 since I've been practicing in Texas, and that's been quite a while. But they should be doing it in the hospitals, and particularly now because of the increased liability, hospitals should be establishing respiratory protection standards if they have not in the past. And that's all I have. Thank you.